today about surgical ICU management, which is actually very essential topic, as sir mentioned, because we know how to take care about patient in wards, but we are not able to manage patients when it is in ICU. ICU is an intensive care unit, which is a special unit, which is concerned with the care of patient with a critical illness. That is why it is called intensive care unit. What it demands and why it is a special unit, why it is intensive unit, because it demands a broad-based knowledge. You won't be able to treat patient with a limited knowledge, with the very few things in your mind. You have to have an advanced monitor. It won't be like if you don't have a SpO2 monitor, if you don't have an ECG monitor or anything, you won't be able to manage patient in ICU. It will be as similar as a ward. That's why it is a special unit. You'll have an organ support equipments to achieve a good outcome as well, and more sophisticated and comprehensive level of care will be needed. And follow-up is most important in compared to ordinary wards. So that's why it is an intensive care special units. So why we need this surgical ICU? Why its demand is increased? As in the new era, we have increased the operative procedure. We have a broad spectrum of operative procedure. For a very minute disease to a very big disease, we have multiple operative procedures now, which will take a prolonged time, which will have a more intensive operative need. And in that case, we'll need in advanced operative procedure, we'll need to take care of patient more in post-operative period. As long as will take time in OT, patient will be intubated for a long duration. As much as bowel resection or intervention we will do, like for a tumor or for any other procedure, patient will need more care. So to improve critical care services and with the improved critical care services and technologies, we are here to utilize it for our patient itself. So those are the demands are increased because of increase in the procedures and increase in the advancement of the surgical field. So these are the reasons as well, because at times when you are taking more time in operative procedure, it will be difficult for anesthesiologist to take out patient from the anesthesia. So at times it happens that failure of awakening from the anesthesia happens. Surgeries with the high risk complications leading to the patient requiring continuous monitoring and life support post-operatively. Because as a patient is very critical, and like a carcinoma patient in grade 5, like with the heart disease or any other organ morbidities or other disease like diabetes, hypertension, which is not in control, at that time, as patient is required surgery for as a life saving procedure, he'll also require this advanced care post operatively, as he is high risk patient. So we will put that patient into the ICU. So at that time we'll need surgical ICU. So all these things, this increased need and this reasons for the surgical ICU admission are is your admission criteria. There is nothing new in admission criteria. Which patient you will endure in the SICU is the same as the patients you are thinking you are taking with the high risk and for the long OT. That are the reasons for that we developed the SICU. So for admission criteria, as it is an expensive resource area and should be reserved for the patient with the reversible medical condition with the reasonable prospects of substantial recovery. So you won't send the patient who is going to die. You have done life-saving procedure, but when you are knowing that this patient won't survive even after the excessive care, even after the special care in the special unit. So you won't waste the ICU bed in that case. You will use this ICU for the patients who are really needing it and who is having a better outcome. You won't waste this resources because it is important, right? So candidates for the admission to the SICU are the reasons we developed the SICU, as I said before. So high risk patients in perioperative period will endure. At that time, we are keeping in mind that patient is going to recover, right? Post-operative patients requiring continuous hemodynamic monitoring, ventilator support, usually following the prolonged abdominal and GI surgeries, as I spoke before, vascular surgeries, thoracic surgeries, airway surgeries, etc., etc. We are posting patients in the SICU post-operatively. So patients generally which patients are generally not appropriate for the ICU admission? The simple line which are not fit in the criteria for the admission are not supposed to be posted in the ICU, not supposed to be transferred in the ICU. So who those patients are? They are irreversible brain damage patient. That patient who is not going to recover at all. We won't send that patient into the ICU. The patients with the end stage cardiac, respiratory, or liver disease with no options of transplant there. So no point of we are sure that he is going to die. So we will secure this resources for the patient who is in actual need. We won't waste it, right? The brain dead or brain dead non-organ donors. Once the patient is brain dead, but he is an organ donor, in that case, the patient should be in the asepsis. Organ should be fine before we are taking it out. At that time, we are keeping patient in the ICU. But if he is non-organ donor, like he's having diabetes or he's in septic shock, we won't waste this ICU facility for that patient. Patients with the non-traumatic coma leading to the persistent vegetative state, same as the irreversible brain damage. Metastatic cancer unresponsive to the chemotherapy and radiotherapy. We won't admit this patient as well. So ICU management. Till now we have discussed about which patient we will indoor in the SICU, which patient we won't indoor in the SICU. Till now we have discussed about why we have developed ICU, right? Reasons behind ICU, what things we will require in ICU. So once ICU has been developed, ICU, which patient we are sending into ICU is also decided. But who will manage this ICU? So there should be a team. It's a teamwork to managing an ICU. So first of all, as we are sending a surgical patient, surgeon should be a most important part of SICU. Another is anesthetist provider, that is ICU intensivist. Another is sister staff and ICU provider. So surgeon should be knowing which patient I am sending. Surgeon should be knowing which procedure I have done. What are the side effects post-operatively? What are the things to be managed? Like you have resected a large amount of bowel, large length of bowel. Patient might go into the small bowel syndrome. So you must be knowing the side effect of it. So you must be knowing the treatment of it. So once you are sending patient, you should be knowing all the treatment and everything behind the whatever taken or whatever the treatment is needed behind the patient. What anesthesia provider will do? He'll look after the this ICU, this ventilator part, or his respiration, or his blood pressure, and other medicine or cardiac things, right? So ICU intensivist manage on this part. He'll preserve the vitals of the patient. Whenever the tracheostomy is needed, when the metabolic acidosis has happened, how to treat that, how to cure it. You'll look after all these things. When patient is needing the O2 mask, when we have to shift it from mask to the NRBM bag or ventilator, etc., etc. And what nurse is doing, we are going to discuss nurse and surgeon's role after this. This is just a team photo I'm discussing here. So nurse will follow all the orders surgeon and anesthesiologist is given, and we should be connecting. We should be in the team. We should keep the ICU provider in the team because there are many things we are requiring in ICU, like SpO2 probe, mobile SpO2 probe, the BP instrument, or the ventilator, or anything we need. So ICU provider should be there, so we can directly talk with him that we need this thing, we need the IC cannulas, or need the central line. Right now we have this thing is NS not present at present in the ICU, so we can directly talk with him and we can indent the stock. There should not be any excuse that there wasn't an ICU provider, and so reason we have not this thing available in the SICU. Otherwise, you are not doing work intensively, right? Uh, you are not justifying the ICU then. So with this team, what you will do? You will be in a team. You will work like a team. So you will discuss a patient. That a surgeon will tell anesthesiologist that I am sending this patient to SICU. I have done this procedure, and I'll need this follow-ups for this patient. So anesthesiologist will say, I'll take care of this respiratory and cardiac issues and peripheral vascular blood pressure and any other things. And nurse will take care of all the orders of surgeon and all. So this way in channel, we will discuss, we will send the reports, we will check the reports, we will talk, and we will give the treatment. So in teamwork, we will do all these things. So What are the duties and responsibilities of a doctor in ICU? So we have to do a physical examination. We have to assess the patient. Interpretation of diagnostic tests we should done. We should manage the airway. It's not just anesthesiologist duty. If anesthesiologist is not there and patient is in tachypnea or patient is in gasping, we should be knowing that how to manage the patient, how to intubate the patient, and how to cure the patient, when to start O2, when not to start O2. We should know the pharmacological management of any condition in the ICU patient. We should be knowing the CPR management. We should be knowing the emergency cardioversion, defibrillation, catheterization, invasive ventilation. When should we should give discussion and management of concerned surgeon and physician should be there. It should not be like one person is managing the thing. It should be a teamwork. And one surgeon or anesthesiologist or a person is thinking that my knowledge is limited now, then he should not hesitate, should not be hesitated. He should directly discuss with the another or senior surgeon or a senior physician or anesthesiologist for the betterment of a patient. Appropriate documentation should be there as the patient is critical. The RBS charting, blood pressure charting, the investigation charting should be there. So you can be knowing that drain output is this right now. It's more now. It has been decreased. The count is more right now. It has been decreased now. So treatment is working. Or sometimes it happens that drain output was less, now it is higher, so bleeding is there or not. So sometimes counts are low and now it is higher, so patient is going in the sepsis or not. We should be knowing that by charting. So when there is a charting, you can get to know, right? So appropriate documentation should be there. Prescription and update of therapeutic plans should be there, and it should be discussed. It should not be like you have wrought, you have gone, it's done. It should not be like that. It should be discussed with each and every person in the SICU, posted as a duty person in SICU. Carrying all technical procedure by own self. Like once you have to insert the central line, it should be done by yourself. It should not be done by any nursing staff or any other person. Communicating with the patients and relative and referring hospital should be done by your own self. It should not be done by anyone else, because you know everything about patient. You should talk with the relatives. You should not keep it on any other person. Acute and chronic pain management, you should know that patient is in chronic pain or acute pain, you should give treatment accordingly. So now what are the nursing staff's duty? So provides professional nursing care to for the comfort or and well-being of the patient is nurse duty. Evaluating general conditions of patient, like implementation of doctor's advices for the individual patients. Coordinate care delivery and education through the collaboration with the patient, family, and all healthcare team providers to ensure safe and effective quality patient care. Performing professional, clinical, and technology competency with the which includes vitals monitoring, RBS charting, ET suctioning, proper care for peripheral or central IV lines, frequent changing of position of the patients, maintaining proper patient's hygiene. This thing should be done by the patient, by the sister itself, by the nursing staff. So and this thing done and washed by sister, like some few things like patient's hygiene she has to look after. Like she has to teach patient's relative that you have to ask patient to do a betadine gargle, or you have to change the position of patient, or you have to sponge the patient, you have to ask patient to change the clothes, etc, etc. If he's or she's patient is bedridden, she has to help, she should help the relatives, or she should guide the relatives, or she should take help of a servant staff over there, right? So these are the duties of nursing staff over here. So what basically we focus in SICU, what team focus on SICU? So we give, one is life support and another is monitoring. So what life support we give? We give a general, we do a general thing, general care of patient. We look after the CVS and respiratory things, systems, renal and CNS and metabolic system as well. But in metabolic and CNS system, anesthesia and physician people are doing more, but we should be knowing superficially that when to call a physician, when to call an anesthesiologist. It should not be happen like report has came since afternoon or since morning and we are not calling anybody. Patient is lying, report is there, anesthesia person will come, anesthesiologist will come, he'll see and he'll treat. It should not be like that. You should be knowing when to call a proper person, proper doctor. So for that, you should be having a basic knowledge. So this thing, the life support, what life support we are giving, we have to monitor all that life support. So same thing, CVS, Respi, Renal, CNS, and metabolic input output we have to chart and we have to monitor. So in life support, as I said, we have to give general body care, and that should be mostly done by the nursing staff. That is changing position of a patient every hourly, because they all are bedridden. That's why they are in ICU. So we have to change position. Otherwise, what will happen? Patient will have bed sores. That is most commonly seen in surgical patients, as they are bedridden. Even in other patients, but in surgical patient post-operatively, they won't get up and they won't ambulate themselves, and this will happen. Other are body and mouth hygiene. As I said, they should be get sponged. They should be have a betadine gargles or clean mouth. Bowel and bladder care. If patient has passed stool, it should be clean. Diaper should be changed. If patient has passed, the catheter is full, it should be emptied timely. It should not be like it is leaking or it has got torn out. That should not happen. There should be passive and active physiotherapy done, and adequate nutrition should be given. Pints are going, that doesn't mean patient is adequately getting all the nutrition. You have to look after the nutrition as well. Otherwise, patient will go into the malnourishment, and malnourishment won't let your patient get improved, right? So that was about the general part. Now we will go on to the respiratory care and the CVS care. So in respiratory care, what we will look after, what basic knowledge one surgeon should have, that should be using oxygen support judicially. You should not give a high amount of oxygen to the patient who is not needing it, or you should not be giving a low amount of oxygen to the patient who is actually or genuinely requiring it. For that, you should be knowing when to give CPAP, when to give BiPAP, and how to operate CPAP and BiPAP, how to use this nasal cannula, simple mask, NRBM mask, and high flow O2 mask, O2 devices, right? So you should be knowing this table. It should be learned by heart, because at times I have seen in my wards as well that residents are starting an RBM mask and giving O2 at the 8 liter per minute flow. It won't work, because this bag, to inflate this bag, it will be needing this 10 to 15 liter of O2 to inflate this bag as well. And when it is inflated, then and then only it will give O2 to the patient. So you should be knowing, once a patient, the resident will give nasal O2 with the nasal cannula, and he will start O2 at 8 ml per 8 liter per minute. It won't work, because it is able to give just 6 liter maximum. So 2 liter are getting wasted, and patient is still in tachypnea. Why? Because you are giving 8 liter, but by nasal cannula. So nasal cannula's capacity is not of 8 liters. So patient will suffer. So you should be knowing which instrument is which this thing is giving how much amount of O2 and how much amount of FiO2. Patient is needing 10 liter of O2, but he is requiring FiO2 of 60%. What will you do? You will give NRBM mask, or you will give a simple mask. At that time, you will see if patient is maintaining on 8 liter at 60% FiO2, you will continue this NRBM mask. And if patient is not maintaining on that, you will give 10 liter of O2, and with this 10 liter of O2, but with the NRBM mask. So patient will get sufficient of amount of O2. This is about the respiratory care, when to give how much amount of O2 and with the what device. So now after respiratory, on CVS care, what we will do? In CVS care, we will achieve adequate tissue perfusion by giving proper fluids, optimizing vasodilator and vasoconstrictor use. When patient is in hypotension, when patient is in hypertension, what to give, when to give vasodilators, when to give vasoconstrictors, right? That should be one person knowing. ECG monitoring should be done for danger signs. So when you are visiting this ICU and you are not knowing that what ECG signs you should be knowing, and ECG changes are there, and you are just standing, you are visiting patient and you are leaving ward, and patient is went into the MI or in the any other cardiac arrest due to patient and ECG changes are there, and you are not able to diagnose, and patient will suffer. So that should not happen. So we will discuss this ECG changes in later stage. Before that, we will see look after this renal care. What renal care we should be giving? So we should be maintaining adequate fluid and electrolyte balance, and correction of any abnormalities should be done. Monitoring of input-output charting should be there. It should not be like you are giving 2,500 liters of water or pints and output is just 500 ml. It should not happen, right? When there is output is just 500, you should reduce the input then. Otherwise, cardiac load will increase. So you have to keep monitoring of input and output charting. Avoid hypovolemia, hypotension as well. Avoid use of nephrotoxic drug, especially in those with the compromised renal function. So what hemodynamic, now we have taken care of this respi, renal, CVS, etc., etc. Now we will start on monitoring. What monitoring you should be knowing. So for cardiac ECG, for ECG and NIBP, non-invasive blood pressure, you should be knowing. You can take care of this CVP, but CVP you won't be able to. As being a surgeon, we are not knowing CVP more, central venous pressure more, but that part anesthesiologist will be monitoring. But you should be knowing that he is monitoring or not. In respiratory monitoring, you should be knowing ABG, capnography, pulse oximetry, temperature monitoring should be there. So patient should not went into the hypothermia or hypothermia, and RFT monitoring should be there. So in ABG, you should be knowing the pH, PCO2, PO2, and HCO3 normal value. This normal value should be on tip of your tongue. So you can decide patient is in metabolic acidosis or metabolic alkalosis. Patient is in respiratory acidosis or patient is in respiratory alkalosis. You can be deciding this metabolic from HCO3 and respiratory from PO2 and PCO2. And by pH, you can decide this thing. So these 4 measurements are most important to decide this respiratory or metabolic alkalosis and acidosis, right? So you should be knowing this. So metabolic acidosis and alkalosis, I'm not discussing right now because it's it itself a huge topic to discuss. So that will be discussed in another session. You should be knowing that thing, but these 4 things should be on tip of your tongue. If you are not able to judge metabolic acidosis or alkalosis or respiratory acidosis alkalosis, you should be, even if you are knowing these values are altered, you can call physician or anesthesiologist. That just do come and check this. This is not normal. Just do whatever is needed, right? So you should be knowing normal values. So after this ABG respiratory part, we will look after the ECG. In ECG, being a surgeon, you should be knowing hyperkalemia, hypokalemia, and this MI. These 3 things are important because patient can go into the cardiac arrest due to this myocardial infarction or in the hypokalemia, which is the most common post-operative complication in the surgical patient. So in hypokalemia, what will you see? That is the ST depression you will see. If there is an ST depression in ECG, you should call physician and you should start giving the potassium correction. You should send the electrolyte blood investigation. So you can be knowing that potassium is genuinely low. If it is borderline low, you can give the IV KCl just 1 ampule. If it is more low, you can infuse more amount of potassium by KCl, and if patient is tolerating orally, you can give syrup Portchlor or etc. potassium supplements, right? And when patient is in hyperkalemia, patient will have tall T waves. So that is also important. So when there is tall T wave, when there is ST depression, you have to think about potassium electrolyte imbalance. Another thing is anterior wall MI patients are in surgery, they'll have a typical ST elevation. ST depression is potassium, low potassium, that is hypokalemia. But when there is ST elevation, that is your MI. Don't get confused between tall T wave and ST elevation. Tall T wave will have this triangular impression, just triangular impression. But this anterior wall MI have this storm-like appearance, this continuous, this storm-like appearance, this way. And this is having this ST dip, and after that, this triangle. Right? This is hyperkalemia. And this is MI. Pulmonary embolism is also important. In that, you have to see this S1, Q3, and T3 pattern. This S1, then you will have this Q wave, and then you have T deep T. That is T3 pattern. Right? So you should be knowing this important things. In respiratory monitoring, as I said, You should be knowing if patient is not maintaining on nasal prong, you should go on the ventimask, not ventimask, then NRBM, not NRBM, then on the ventilator. In ventilator, IPPV, CPAP or BiPAP, you have to decide. In that, before that, you should, once you are knowing the ABG, you should be knowing this risk of type of respiratory failure. According to type of respiratory failure, you will decide target SpO2 needed, and according to target SpO2 and this ABG monitoring, you will be able to decide on which devices you will keep the patient and how much O2 patient will require. Right? This chart I'm not elaborating right now. You just go through it and read it, and you will get to know. I'm just getting the points you should be knowing for the SICU, right? The basic knowledge I'm giving right now. Clinical importance of capnography. This is the part of respiration as well. We are not able to do a capnography, but we can call anesthesiologist or physician for capnography. Because why it is important? Because it is a sure sign of endotracheal intubation, detection of untoward events like disconnection or inadvertent extubation of a patient, cardiopulmonary resuscitation, weaning from mechanical ventilation, and monitoring the non-intubated patients. In these patients, we can decide if the ventilation is more needed or not. If patient is when patient is need the intubation, patient is non-intubated, but you are not able to judge that patient is needing intubation or he is needing just more amount of FiO2 and more long duration of BiPAP or etc. Right? At that time, you will able to decide with the help of capnography. So these are the indication for capnography. So now Respi and CVS are covered in the part of monitoring. So what other important aspect you should know is renal function. In renal function, what you will look after? So most importantly, volume. So normal volume of renal output is 0.5 to 1 ml per kg per hour. If there is less than 0.5 ml per kg per hour renal output is there, patient is in oliguria. So we should think about the causes of oliguria. Is it the pre-renal cause, renal cause, or what cause? And accordingly, we should give the treatment. We should need to flush the kidney, or we should just we should give the bicarbs, or what should be the line of treatment should be decided with the volume first. What other monitor is there? There is urine creatinine out. We should look after. That is 0.4 to 1.4 is normal. If more than 1.4, the kidney is compromised. We should think about other treatment. Urine osmolality is also important, which is not done routinely, but we can get it done when we need the renal function monitoring. So in that, if there is osmolality is more than 500 milliosmol per kg per H2O2, so patient is in pre-renal azotemia. And if it is less than 350, so you can think about acute tubular necrosis. So you can call physician at this point of time for further treatment. So this was about the till now we have discussed admission criteria, reasons for the SICU, what care we should give, what to monitor in the SICU, and how to treat the patient, right? When to treat the patient and when to call other doctors, other team members. So now once we have done all these things, we have give all ICU intensive care. So now patient is fit and fine, and you are thinking to transfer this patient. So which patient you will discharge? How you will decide this patient is dischargeable or not? Discharge doesn't mean that you are directly discharging patient from ICU to home. It should be, it can be ICU to home, it can be ICU to other ward or normal routine ordinary ward. So which patient comes under this discharging criteria? So that are the stable, hemodynamically stable patients. Respiratory status, it's normal, like patient is extubated with a stable ABG with a patent airway. No need for any IV inotropes or vasopressor supports. Neurological stability, if patient has achieved cardiac dysrhythmia is controlled, patient is no longer needed any fibrillator or anything. Patient is requiring chronic mechanical ventilation with their acute critical problems are reversed and resolved, can be shifted to the ward with the ventilator facility. One patient has acute attack or of respiratory arrest or etc. So we have shifted that, and he surely live long, right? So we are giving him to we are posting him in the ICU. We are doing everything for that patient, and once patient is recovered from this acute phase, he is stable now, but he needs ventilator for the long duration. At that time, what we will do? We will shift that patient on ventilator to the any other ward or ordinary ward where the ventilator facility is there. So now patient is not requiring continuous monitoring. Patient is stable hemodynamically. He just need this ventilator. So we will shift him to the normal ordinary ward with the ventilator facility, right? Like you have noticed in TBCD ward or any medical ward. So patient whose physiological status are stabilized and no longer need of any ICU monitoring, we can shift that patient as well. So these are the discharging criteria you should be knowing.